Hello, I'm Jeremy Otte, the Director of Outreach and Education with the Wisconsin Parkinson Association. WPA provides hope, community support, and resources for people with Parkinson's and their loved ones. Today, we are here to provide you with information on WPA, share information on Parkinson's disease, and introduce you to people in our community who have a Parkinson's connection. Today, our guest is Dr. Rachel Biemiller, a movement disorder specialist with Gundersen Health System in Crosse. Dr. Biemiller will discuss how vision and falls may impact people with Parkinson's disease. Welcome, Dr. Biemiller. Thanks for joining us.
You're very welcome.
Great. Well, why don't we start with the easy stuff? Why don't you tell us a little bit about yourself and what you do at Gundersen Health System?
Sure. So, as you said, I'm a movement disorders trained neurologist. That means I went through 4 years of neurology training, decided I just wanted more school, so did 2 extra years in focusing on movement disorders. I got my training out in the University of Rochester, which actually has a large movement disorders group out there and is known for research. And the training I did was a combination of diagnosis and management of Parkinson's, deep brain stimulation, as well as research and translational studies. So I came out to La Crosse here, and I love it. I'm one of 2 movement disorders doctors here at Gundersen Health System. I'm currently the chair of the department as well. And we do deep brain stimulation, we do Otte out here, pretty much everything you could think of for Parkinson's we do. And we also do outreach to the community. I currently have 2 clinics that I go to in northern Iowa as well. So.
Excellent. Well, we appreciate you taking the time to join us, and with us being in southeastern Wisconsin as WPA, you've written a lot of articles for our magazine over the last couple of years, and one of the topics you've touched on is vision. So I wanted to touch on, how does vision impact Parkinson's disease?
It's actually multifactorial. So it can affect both acuity, it can affect eye movements, it can affect color, perception, as well as visual processing. And all of these things are involved with just everyday sight that we don't think about. So the first thing that I'll talk about is actually the motor symptoms, as we think of Parkinson's and motor movements typically. So in Parkinson's, people have stiffness, they have rigidity, they're very slow, and the eye muscles are not exempt to this. So one way that we can actually diagnose Parkinson's, or it's a sign of Parkinson's, is what's called choppy pursuits. So when a person follows along an object, you're watching a car go by, or you're watching a flock of birds, typically what you do is you fix on that object and the eyes move along at the same pace as whatever you're looking at. And if you watch somebody move their eyes, you can see this nice, smooth movement. Now in Parkinson's, as people try to track along watching that object, they can't keep up because their eyes are slow, just like everything else. So they have to initiate what's called saccadic movement. So what saccadic movement is actually what most of our vision involves. It's where we jump from one thing to the other. You look at the dog, you look at the tree, you look at the house, you look at your friend, you look back at your dog. It's these quick jump, jump, jump movements. So instead of slowly following an object down the road, because your eyes start to lag behind, you have to do a quick catch up. So you'll do jump, 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 trying to follow that object, trying to constantly keep up. So if I were to sit in front of you and have you follow a pencil with your eyes, instead of seeing a nice smooth movement, I would see jerk, 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 jerk as your eyes jumps trying to keep up. We'll also see this sort of delay in movement when someone looks over at something. So if you're ironing your clothes or whatnot and someone comes in through the door and you look up, instead of your eyes being able to make that target to whatever you're looking at, it may fail and not go quite so far because of that stiffness in the muscles. So then you have to do a second jump to reach the target. So instead of one big long jump, you have to do 2 small jumps to try to get to that object. So again, that stiffness in the muscles are causing a problem. Another issue that people will complain about a lot involving the muscles of the eyes would be double vision or blurred vision. This is particularly noticed when looking down or looking at something close in. So if you think about our eyes, because we have depth perception, our eyes have to yoke with one another. That's how we are able to put 2 images together into one. Our eyes have to be exquisitely sensitive to be able to do that. If our eyes are off by even a millimeter, we start to blur or even see 2. Our eyes are yoked actually in the back of our brainstem, so they move seamlessly together, and we don't even have to think about bringing them into focus. So when we look down, in particular, our eyes move towards our nose, kind of like if you're going cross-eyed, but not that extreme. When the eyes try to do this to focus on, let's say, reading, looking down at the dashboard, going downstairs, the stiffness in the muscles sometimes won't let the eyes fully come into focus. And this can cause blurred vision, this can cause double vision. Now, sometimes if you give it a second, the eyes will eventually come in, and then people are able to read. But some folks, either they never come in, or even the slightest movement, the eyes have to consistently try to reset. So whenever they look down, they constantly get double vision. This can be extraordinarily hard when you're trying to read. You look down at that book, the words are always doubled, or the lines are doubled, so you have difficulty following along which line you're actually on. I've had patients say they go downstairs and they see two stairs or kind of a shadow step because they have that second vision or second image that they're seeing. So it can be really, really detrimental. And sometimes carbidopa can fix that if you can loosen up the muscles, but sometimes it doesn't. Sometimes prisms, which is an insert in the glasses, can bend the light that can adapt for the insufficiency. It's mainly used for reading, but if the eyes are constantly changing how far apart they are, it doesn't always work. So it can be fairly debilitating, and sometimes will affect people driving in particular if they go back and forth between the dashboard, and every time they do it, they keep getting double vision as their eyes try to reset.
I think that's a great point. You talked about, talking to the doctor about some of the tools that are out there, because I hear from not just the patient, but the caregiver once in a while, where maybe the spouse was an avid reader and really that was their hobby, their free time, and now they're not reading at all. They're not engaged that way. And the caregiver kind of worries, well, what can we do? So I think you've touched on, there's a few things they can do. So they definitely should talk to you, because that may be a common Parkinson's symptom is what I hear.
What I tell everybody, it's always worthwhile to bring it up because there's actually quite a bit we can do for things. The worst case scenarios, I'll tell you, there's nothing I can do. So you've lost nothing to bring it up. Weird symptoms like what's called eyelid opening apraxia. It's where your eyes close and your brain temporarily forgets how to open them. So people will sit there and their eyes just stay closed and they're trying to open them and they won't. That's something we can actually treat with something called amantadine. It's an old Parkinson's medication, and it works fairly well, at least in my experience, to help overcome that. Sometimes if folks have the eyes just seem to want to close, you can actually Botox the eyelids as well to try to loosen them up so they're easier to open. So again, a strange symptom that actually we can help.
Excellent. I think what you said is great. The worst you can say is I can't help you. And I think I've always told people when I talk to a support group, not everything is because of your Parkinson's disease, but you don't know that till you ask the Parkinson's doctor. So I think that's great that there are options. I'll let you keep talking about other things that are impacted by vision, or how vision is impacted.
So the last part was the motor. I mentioned the eyelids just briefly with the eyelid opening apraxia, but that would be a decrease in eye blink. That's something that goes along with what we call those masked faces. If you want to sound smart, the appropriate term is hypomemia, but it gives you that Parkinson's stare. And the problem with that is that it can cause the eyes to dry out. And then what the eye will do is try to produce more tears to compensate. But the eyelid's like the windshield wipers. It pulls the tear from the bottom and pulls it across the eye. So if the eyes aren't blinking, then the tears just pull at the bottom of the eye, and then you have tears running down your eye. So I have folks say, my eyes are dry, but I'm tearing all the time. Well, that's why you're not blinking enough. Again, sometimes carbidopa can help that because you're moving better, or simple eye drops can be helpful. Or if you just notice your eyes are starting to dry out, remember to blink. But that can actually help as well. Now, moving on beyond just motor movements, the other thing that we've noticed with Parkinson's is that visual acuity seems to change as well. It ends up decreasing, so you don't see quite as well. So yes, there's normal eye changes as we get older, as the eye itself changes shape with aging, but Parkinson's itself seems to actually change how well you see. That's also not just acuity, which is the sharpness of your vision, but also the quality of color as well. And the theory behind that right now is that the protein alpha-synuclein, which, just to bring everyone up to speed, is an abnormally folded protein that we find in Parkinson's disease that seems to junk up the systems, for lack of a better term, seems to build up in the back of the eye. And so there's some thought that it's interfering with the eye function. It actually changes the thickness of the retina, and that can be noticed on eye exam with certain imaging, retinal imaging. There has been some discussion whether Parkinson's could be diagnosed before other symptoms come about, by this type of imaging. Now, it's been researched a little bit, but not extensively because we don't have any disease modifying agents right now. So I tell my patients, medicines that we have make you feel better, but it doesn't change the progression. So at this point, spending a lot of money to do that early diagnosis may not be as helpful right now. Now that may change with some of the research that's coming out. So in the future, this may be something that we start screening people with if we have a drug that can actually slow down the progression.
You're talking about a retinal scan that you had probably done like at your eye doctor?
Yes, it's done by ophthalmology. It's not like an MRI or anything like that. I actually spoke to one of our eye doctors a while ago about it, and it's like, oh yes, we're familiar with this in the literature, but it's not been aggressively studied because, again, the response is, well, it's interesting, but there's no actual benefit right now at this point to do it, but that might change in the future. So kind of an interesting piece to that. The other thing that they were noticing is that the transmission down the optic nerve. So the way vision works is that the light and whatever you're seeing bounces into your eye and projects on your retina at the back of the eye, much like a movie theater. It then is that image is then taken up by the optic nerve, which is a big old fat nerve in each eye that pulls the image back and brings it to the brain. Once in the brain, the picture is recreated, it figures out what the picture is, and then it attaches meaning to it. If you're looking at a car, oh, this is a car is something we drive, and then it orients it to space, and that's how we actually process what we're seeing. It's actually a much more complicated process than it's just saying, I saw a car. What we're finding is that transmission can be slowed down into the brain, and then that processing is also slowed. It doesn't mean it stops it from happening, but as far as taking what you're seeing, interpreting what that image is and what it means and how it relates to you can be a slowed process. Now, again, we're not talking minutes to hours, we're talking fractions of a second. But if you have something like a baseball getting thrown at your face, there might be a little bit more of a delay than with somebody else who doesn't have Parkinson's. So you may be more apt to get smacked in the face with that fly ball. But again, as most folks with Parkinson's have noticed, that even thinking slows down with Parkinson's. Everything just kind of slows down a little bit, and that's part of that visual processing as well. All the functions of the brain, just for whatever reason, we're not 100% sure, just seem to slow down. And again, I've had folks say that the carbidopa-levodopa does seem to speed even the thinking and processing up a bit for them. So there's much more to the brain that we don't understand.
Oh, isn't that true? You talked a little bit about, the depth perception, acuity, etc. One of my questions, I hear a lot of people tell me, I'm going to go to the eye doctor, I'm having trouble. Do you find a lot of ophthalmologists are aware that this may be an issue with Parkinson's disease, or are they just treating it as a normal eye issue? And I don't want to cast a huge umbrella because I know every ophthalmologist is different, but just kind of in your experience.
From what I've seen, most of my patients actually go to optometrists as opposed to ophthalmologists. If it's a simple acuity issue, they typically don't say related to Parkinson's. There is some evidence as well that you can get light sensitivity because the pupil doesn't constrict fast enough and you go into a bright room. And I frequently won't say that the optometrist will pick up that could be Parkinson's. It's pretty rare. I've only seen like once or twice, but they don't typically mention it. Now, if I ask an ophthalmologist off the cuff, oh yeah, I'm familiar with it, but it's not something I think that they're routinely thinking about. Now, if you have an eye movement issue, such as that double vision, that convergence insufficiency where you're trying to focus, that they do recognize as Parkinson's. So the eye movement abnormalities, it just decreased blink rate, the drying out of the eyes, they recognize as Parkinson's. The acuity, visual perception, I'm not seeing as much. I think part is we don't really know to what extent and how much, and at the end, it's still treated with changing your glasses.
Okay. I think you've covered a lot on vision. I think you've done a great job. I think it's answered a lot of the questions I've had people have me. Is there anything else impacted that we haven't touched on before we get into maybe how vision and depth perception may increase risk for falls for people with Parkinson's disease?
Actually, that's what exactly I was about to say as far as affecting walking, because balance in general is a combination of sensation in your feet, in your ear, and then vision. So if you can't see where that step is, you're going to misjudge and you're more apt to fall from that. Same thing as if you're trying to cross the street, you're trying to track cars, all of those things are going to affect how you move and where you feel like things are in space.
So we'll jump into falls then. We just talked about how vision obviously may impact that. Are people with Parkinson's more susceptible to falls, and why would that be?
Unfortunately, that is true. So the typical aging process increases our risks of falls, mainly by a combination of weakening of our large leg muscles, what I call the hip flexors. So these are the muscles that allow you to lift your leg up at the thigh and get you out of a car or get up off of the floor. These weaken just naturally with age. I mean, I'm in my 30s and they're weaker than I was when I was in my 20s. So it happens just across the board unless you're actively exercising them. And then a lot of patients will get dieback of their nerves, which is where the sensory nerves in their feet that kind of tell you where you are in space, they just get damaged. And that can be from diabetes, natural aging, any of the above. And therefore you can't feel as well. And so people who are, as they get older in their 80s and such, you notice their base is a little bit wider, more of a triangle shape, to try to make themselves more steady as they walk. And that works for quite a few people. So in Parkinson's, you have that as well, because it's just part of the natural aging process. But then you get some other fun stuff. And we will go back to the motor to begin with. So you have the motor movements affecting your walking. So how is that? Well, one is you're not going to be taking those big, even strides like you normally do. You take those sort of small little steps, so you're more shuffly. This makes you more apt to trip over things, particularly carpets on the floor. That's always a big one that I hear about. Uneven ground is going to be a little bit harder as well because you're doing these little shuffling movements. And then you'll also, people will notice.
Can you repeat that? Because it's always counterintuitive when I talk to people about big step versus small step. And I said, you're more likely to fall when you take a little step. And they go, no, it's better balance. But can you reiterate what you just said is it actually increases your risk for fall?
Right, because you're not lifting your foot up. So you're barely making that ground clearance, right? So yes, the big rug in the middle of the floor is an obvious one, but even like a plush carpet, it's a good example, or your sole of your shoe can actually get stuck on the floor. But then if you think about you're walking outside in your garden, because we've all need to start weeding here pretty soon, if the ground's uneven, you're more likely to, again, catch your foot on whatever you're walking on, and then you're more likely to fall over. Not only that, but I'm going to jump ahead a little bit here, but with Parkinson's, as you know, we tend to lean forward more, and then this is going to move your center of gravity in front of your feet as opposed to over your feet. So what you have to do is you really take a bigger step to keep your balance. But if you take these little small steps, then you can start tipping forward more and more and more. And then people have to move faster and faster, faster to try to keep up. And eventually you end up, head over tea kettle in the grass somewhere. So bigger steps are also more likely to have a more even stride. We think that big step, big step, big step, big step, because a lot of times with Parkinson's, well, always in Parkinson's, one side's worse than the other, and people may find that one leg just doesn't move as well. They may take a different length of stride, which will throw people off, or they'll even drag it a little bit, and that will throw people off from walking as well. Along with that, there is the issue of freezing, which people don't know, they recognize as soon as they have it, but it's not something people normally talk about because it's a pretty rare phenomenon. It's in Parkinson's and a few other disorders. And this is where the feet just get stuck to the ground. You literally freeze and the feet won't respond. And we don't really know why this happens. The best way I have to try to describe it to people is the autopilot gets stuck, or a scratch on the record. You just get stuck there and can't move. This can obviously cause a big problem with falls, because if you're walking along, you tend to get stuck and then you can tip over, particularly if it's just one foot. Now, I've seen a lot of folks that they'll develop this freezing when they're doing that faster walk, and then it increases the risk of falling forward because then the feet just stop and they tip straight forward. When you do that sort of big step, you're having to focus on your walking, which is kind of annoying if you think about it, because it's something we just do naturally, but you're taking that away from the autopilot when you do that, and you do those nice, large, smooth strides, you're less likely to freeze as well when you do that. You're not catching it on that autopilot. There's something called cueing, actually, where people essentially learn to walk in step to a song. I did marching band for years, so it makes sense to me. And sort of, again, walking on a beat, 1, 2, 1, 2. And it does the same thing as taking that big step. It kind of teaches your body to walk on that beat. It takes it away from that autopilot, and it can decrease freezing. Now, it doesn't mean you have to listen to, your iPad or iPod every time you go somewhere, but even just practicing once a day with a song can actually keep you on that rhythm. It's something that physical therapy can actually do, and it's actually been shown to be pretty helpful for that freezing. And
I've seen it when people dance. They're thinking 1, 2, 3, 1, 2, 3. I did a dance class about 6 years ago where I saw a guy who came in, shuffled gait, bent over in a walker, and a half hour in, he was dancing across the floor like he'd been a ballroom dancer his whole life.
mm-hmm.
And what he said after that is he always just kept that 1, 2, 3 rhythm in his head. And he had a lot less freezing episodes.
Yeah. Again, why is a good question. Again, I think it must be a different area of the brain that's working. I use the term autopilot. I've made that up. It's just what makes sense to me. But again, if you seem to kind of change the function, even if you don't want to count, we'll tell folks to march and step if you freeze, or step over a line, or kick that tennis ball that you always see people hang from their garages. Can sometimes break that freeze if you're sort of resetting things. Not 100%, but it works pretty well. The other thing with walking with Parkinson's is the loss of the postural reflex, and that's a big one. So a lot of these things, such as the shuffling, the dragging one foot, even the freezing, a lot of times therapy and medications can actually fix some of this. Even we always say deep brain stimulation worsens balance, and that's true, but if your balance issues because one side isn't moving as well, the DBS will actually work with that as well. Postural reflex is its own thing. They actually added it as one of the main symptoms of Parkinson's. And this is the ability to catch oneself when you start to get knocked over. So when you go to your doctor's office, they do that test that everybody hates, where they stand behind you, grab you by the shoulders and pull. People just groan and, do I have to do this, Dr. Biemiller? That is what we're testing, is that postural reflex. So we give that kind of sharp pull back. Your feet should engage, your back muscle should engage, try to catch yourself so you don't tip over. That can go away in Parkinson's. Now, when that happens, it tends to be a little bit of a later finding, but the reflex itself, we can't get back once it's gone. And then it increases your risk of falling. So a big one is when people go to open up the refrigerator and there's that suction. So you've got to do that little pull, little jerk to get it over that suction. That's enough to pull you off balance and backwards you go because you can't catch yourself. That doesn't mean we're completely helpless with that. I do still send folks to physical therapy, mainly learning to compensate for that loss of reflex and how to get up, how to move, how to sit down, because if they know that reflex is gone, then there are different ways of doing things to decrease that risk of falling.
I think you've given them all some really good tools. I think you've touched on a lot of reasons. I think the one thing I really just liked was you explaining why you do that pull test during the exam. I've had a lot of people tell me, I go in, I tap my fingers, I tap my feet, and then they make me walk, and then they push me, and I think it's one of those where a lot of patients aren't fully explained why we're doing all, or why you're doing all that. So I think just touching on that little bit was really important for them to fully understand. There's certain things you're looking for each time you do those tests.
Well, we're not doing it because we are bored or just to do it to bill your insurance. It's part of the Unified Parkinson's Disease Rating Scale, Movement Disorders Edition, and from the Movement Disorder Society. And it looks at all these different areas of Parkinson's. So again, that pull test that everybody hates is to check that postural reflex. So it just gives us an idea of how bad that balance could be. Now, I tend to be a physical therapy cheerleader. If someone barely breathes the word, I'm a little unsure of myself, physical therapy. I feel like I'm gonna fall, physical therapy. You could just say I need physical therapy, okay? Because I think everybody above the age of 65 should get physical therapy once a year to work on their balance and walking. It is so important to keep those muscles strong and keeping the brain engaged, because again, you don't use it, you lose it, not just with muscle weakness, but also that brain engagement. Something the brain's not using as much, it tends to start to break down pathways. So anything you can do to keep things moving and even make you feel more secure, because sometimes being taught how to just get up out of a chair differently or get in and out of a car differently can be huge at decreasing your risk of falls. And I'm such a bug about falls is because Parkinson's disease itself typically, and there's some exceptions, but typically it doesn't kill you. The two areas that can are your falls and then your swallowing. And that's what's going to set people up for mortality in Parkinson's or their death rate. So yes, Parkinson's isn't going to kill you, but it's going to make you shuffle, which then you're going to trip over something. Then you're going to smack your head open on the concrete. So with the falls, we worry about head injuries, even if you don't crack your head open on the concrete. Just the brain joshing around in the skull can cause problems. There's a little micro trauma that can affect balance as well. It can cause fractures of the neck. The big one people talk about is their hip or their leg, and then you have complications from that. If you don't paralyze yourself from smacking your head or your neck, you may have to have surgeries, which they can lead to infection risks. You have risks with general anesthesia. Then there's blood clot risks. And then if you get through all of that, that's not enough. Then you have to then rehab. And the problem is, the longer you're out of commission, the weaker you get. And the older we get, the faster that happens. So a good example is I had my baby about my youngest about 2 years ago, monster baby. She laid me out of commission for about 2 weeks. I could barely move. And by the time I could get better, I realized just walking around the house, I was starting to get aches in my calves and my legs. I tried to actually pick her up, getting out of the bathtub, and I almost fell over because my legs had weakened so much. I couldn't lift her and myself up off the floor as easily. So that was 2 weeks for me, again, in my 30s. If you're in your 80s, that may only take a couple days to get that way. So you're looking at a much longer rehabilitation time to get better. And then the Parkinson's itself, your body's under duress, you get worsening symptoms, you take longer to rehab. So it's not that you can't get back to where you were, it's very, very hard. And sometimes people do lose some of their independence altogether after those falls, which again is something we're trying to avoid. I mean, nursing homes and assisted living are unfortunately needed, but I try to put them off as long as we safely can because I want people to be in their own homes. But it certainly can be a huge risk for folks, and particularly if they have falls again and again. You're doing more and more damage to your body, more and more damage to your brain, and then it just sort of accelerates. If you have other health issues on top of it, it can tend to snowball. So I'm a big bug about getting people into physical therapy. I'm a big bug about exercise. What we do know is exercise, again, as I mentioned, keeps the muscle strong, keeps them active, decreases risk of falls, and it can delay the need, if not prevent, but delay the need for things like walkers and wheelchairs, and then you actually keep your independence even longer. So if anyone's watching this happens to my patient, you know that I'm always asking, so how much exercise are you getting? What are you doing? How are you keeping your legs muscles? How are you keeping engaged? It's a pain, but I have yet to have a patient that I finally convinced to exercise who didn't come back and tell me that they didn't feel better. They always come back and say, I'm just doing a small walk around the neighborhood and I move so much better. My Parkinson's is better. I feel better. So once people kind of get started in that habit, it then becomes sort of motivates people to keep doing it because they just feel so much better exercising just throughout the whole day, not even just when they're exercising. So it can make a huge difference. We know there's that brain-heart connection. We know that exercise decreases the risk of Alzheimer's and dementias. We've not seen that association with Parkinson's, but given that Alzheimer's is in the same umbrella category as Parkinson's, being neurodegenerative, I say what you have to lose. So if there's a small chance it could slow down the progression, do it. Even if it doesn't, you're still going to have better mobility, better walking, better symptom control, and a better, just healthier thinking brain than if you didn't.
And I would say, I mean, you talked about exercise. We at the WPA, we have about 110 exercise groups across the state that we work with, and it can be anything from dancing to boxing to big and to a big refresher or just a regular big class, a power class. So there's a lot of options that are out there. And right now, we're in the middle of COVID-19. Everybody's supposed to be at home. If you go to our website at wiparkinson.org, LSVT Big has some videos we've linked to that can keep you active. Mary Wood from our staff has been doing daily Facebook groups, about a half hour of music and movement programs that have been very, very popular in this time. But then Rocksteady and other programs like that, and dance, all have programs out there to keep you moving. And I think you would probably agree, Dr. Biemiller, not just the Parkinson patient, but this care partner should be exercising as well, because heaven forbid something happens to that care partner, that they have a fall, they end up hospitalized, the Parkinson's patient's going to suffer long-term as well because the caregiver is not there to help them.
Oh, I usually just tell folks, go for walks and take your partner with you, and make it a team effort for that very reason. Because I mean, I'm up to 150 minutes a week of exercise. I'm trying to get to that 200-minute mark because the data is so good just for overall brain health and muscle health and blood pressure and everything you can think of. So I do try to practice what I preach. But another thing that I actually recommended to my father before he passed away, he couldn't get out, is and living up here in Wisconsin where it gets so snowy and cold, is even a simple pedal machine can work quite well. And I've seen them range from $25 to $200, depends how fancy you want to get. And it's basically bicycle pedals into a machine. You can use it for your arms, you can use it for your legs, you can put it in front of the TV, put your feet in and just pedal. And even that is better. You can increase the resistance to help increase the muscle mass, but that's helpful, particularly when the weather is really bad and you can't get out of the house. I typically tell folks, put on the news, get all frustrated and pretend you're pedaling to Washington because it's going to get your blood pressure up. But they do work. And again, they're not particularly exciting, but if you have poor balance, you can't get up on an exercise machine, you can just put it next to the sofa and sit in your favorite chair and watch the television while you do it.
Absolutely. We always tell them any exercise is good exercise, whether it's going for a walk with the dog or the pedal or whatever, as long as you're doing something.
Something's better than nothing. Absolutely.
Well, anything else you want to touch on before we wrap it up?
I actually think I got everything.
Excellent. Well, Dr. Biemiller, we really appreciate you taking the time today. I think your discussion really highlighted how visions and falls can both impact people with Parkinson's disease. But I think you also provided some really good tools and resources for them to address these issues, and remind them, talk to your doctor about it. When you go in, make sure you talk to your movement disorder specialist about some of the concerns you may have. I kind of touched on it during the episode, but right now we're currently working to stop the spread of COVID-19, and we know that we are all safer at home at this time. WPA's programs, support groups, and exercise classes are not currently being held, and will not be held probably until May 1st at the earliest. We will update you soon when programs will be rescheduled, though. Since WPA is dedicated to helping you understand and manage your Parkinson's disease, two of our most important mission priorities are providing you with ways to stay healthy and fighting isolation by offering opportunities to be a part of the larger Parkinson's community. Our commitment to these goals has never been more important than today, when our world has been disrupted and your physical and mental health may be in danger of heading to the back seat. WPA has responded quickly to adapt to these changes to serve you, and you will see with this video link, there's a few ways to be connected. You can join the WPA Movement Music Program. It's a virtual exercise Facebook group that is being coordinated by Mary Wood. She's doing classes live, and you can scroll back through previous workouts to if you missed one. Our staff is still working remotely, and you can reach us at 414-312-6990 with any of your questions or concerns, or shoot us an email at mail@wiparkinson.org if you need resources sent to you. As always, we have endless additional resources at wiparkinson.org, including past issues of Wisconsin Parkinson Magazine, which I think issue 100, Dr. Biemiller did an article on vision. Past e-news articles that have been posted, and videos from previous presentations. Our last two symposiums, we have videos posted that you can view, as well as podcast episodes and exercise resources. I think the most important part is, remember, we are all part of the Parkinson's community, and while we are practicing social distancing right now, we can still be connected to the greater Parkinson community. Soon, we will all have the opportunity to join a community of people with Parkinson's and their loved ones in person. Until then, please reach out to your friends and family, check in on them. Use video chat just to touch with base and wish somebody a happy birthday, or talk to that college roommate that you haven't talked to in 20 years. This is your time to do that. So again, thank you, Dr. Biemiller, for being our guest today. Thanks to everybody else who's watching this, and please take care.